So this is a set of 25 that are either in your syllabuses or available online. We've also provided you with another 10 that, out of courtesy from Dr. Penny, we gleaned from the ACC. And this is not necessarily a plug for the ACC question writing committee, but for those of people who are interested in more questions and what I would consider high quality questions is the ACC has a set of questions. They have a very large question bank, by the way, for people who are just interested in taking questions. I think the question bank is 300 and some questions. It's just amazing. And all these questions are highly vetted, meaning that the question writers all had to take a course, as you recall, and sometimes spend hours debating a single question of whether it's any good or not. So I would refer you to think about that source if you're interested in more questions. We have a sample of 10 from that question bank that will be available to you as part of this course, but if you want more, I would direct you to the ACC. All right, I did, why don't you do odds now?
Oh, you throw me off, okay.
Since I did odds yesterday.
So this is a holdover from the patient who we ended up with yesterday. So this is a 62-year-old African-American man who was referred to as an outpatient because of heart failure with low ejection fraction for 2 years. His past history includes hypertension, treated with valsartan, 80 milligrams twice a day, atenolol 50, previously treated with furosemide and subsequently stopped without sequelae. An ACE inhibitor was discontinued when he developed a cough. He has seen his internist only sporadically and has not previously followed the recommendation to see a cardiologist. He denies any symptoms of dyspnea, fatigue, chest pain, lightheadedness, or syncope. He lives in a small town 50 miles away, and he has difficulty getting transportation, but came today because he got a ride. Thanks, Jim. You institute medication adjustments and make an appointment to see him in a month. He fails to keep that appointment. It is now a year later. For the past month, he's had increased dyspnea. His internist made further medication changes with slight clinical improvement. He's still been unable to work because of dyspnea, and he has been resistant to changing his salt intake. His internist referred him back to you. His medications are now long-acting metoprolol, which was the change we made yesterday, enalapril 20 milligrams daily, and furosemide 40 milligrams daily. On exam, he's gained 6 pounds since your prior visit. Blood pressure is 120/80, heart rate's 50 and regular. Jugular venous pressure is elevated. There's a soft S3 gallop and trace amount of edema. His lab data shows sodium of 138, potassium of 4.8, BUN of 32, creatinine of 1.2, and a BNP of 150. So long stem, short answers. What is the most appropriate next step? Increase the metoprolol dose to 150 milligrams daily. Increase his enalapril dose to 20 milligrams twice a day. Initiate an aldosterone blocker. Discontinue metoprolol and begin carvedilol, or refer for cardiac transplant. So as we're trying to connect to live content, this is very, very similar to the questions you'll be asked on the boards. A clinical case like this with a number of treatment options, some of which overlap a little bit, and so you're asked to make the most appropriate choice between the available options.
I'm glad you're defending the answer.
That's why you had me start.
Yes, I did. I thought through this.
Good, I agree with that. So the majority of you chose increase enalapril dose to 20 milligrams twice a day. So as you can tell, there are several different treatment options. We can go through them. So there are some clues. Let's just go to the options, and I'll walk through each one of those. So increase the metoprolol dose to 150 milligrams daily. We certainly want to treat to the doses of medications which were used in clinical trials, but if you look up, his heart rate's 50 and regular, so he's very well beta blocked. His heart rate's certainly less than 60, so well beta blocked. Initiate an aldosterone blocker. We talked about that yesterday. With a potassium of 4.8, it's certainly getting up there, but it's not higher than 5. It wouldn't be wrong to start an aldosterone blocker. But again, we had those issues with compliance, which directed us away from choosing that as the best option. Stop metoprolol and begin carvedilol. So is carvedilol better than metoprolol or vice versa? There's only been one trial, and that's the COMET trial, which compared short-acting metoprolol, so metoprolol tartrate, to carvedilol. And there's a lot of debate about whether or not that was a fair trial because it couldn't increase the metoprolol dose. Nonetheless, I think it's safe to say that for the purposes of the boards, one beta blocker is equivalent to another as long as it is one of the guideline-directed beta blockers, so metoprolol, succinate, carvedilol, or bisoprolol. And refer for cardiac transplant, I wouldn't do that yet. He certainly hasn't demonstrated that he's sick enough to require heart transplantation, if I remember properly, as class 3, not class 4 symptoms. So the appropriate answer here is to increase the enalapril to 20 twice a day. Now, some of you may be thinking, well, his potassium is already 4.8. Aren't you worried about his potassium going up? I suppose so. But if I were to choose between enalapril and spironolactone, I would think that I would anticipate more potassium increase with the spironolactone. So since we're compelled to do something, I would increase the enalapril to 20 twice a day.
All right, let's go to the next question. It's a little slow, Elizabeth. Unless okay, same patient. The patient's become more compliant with medications and a low-sodium diet. Good interactions with your heart failure nurse and team. His medications now include the change you had advised. In spite of good adherence, his symptoms have returned. He's now class 3. His blood pressure is 100/70. His heart rate is 68. The next best step is workup for an LVAD, initiate Spiro, hydralazine isosorbide dinitrate, cut back the metoprolol dose, and admit for inotropic challenge. These silences are so painful. Get the air with a knife. Is it working, Elizabeth? Do I need to? I'm clicking. Is it not? Am I doing the right thing? It was working so smoothly yesterday.
We jinxed ourselves.
Yeah. Well, anybody want to just blurt out the answer while we're waiting for ARS to? All right, well, while we're waiting for that, I think I heard somebody say Spiro. Anybody disagree? A few. What are some other thoughts? So another potential choice is hydralazine isosorbide. Any other? So somebody said the blood pressure may be an issue here. Oh,
There we go.
all right, let's have people vote. All good points, by the way, people have raised. Initiate spironolactone at 25 milligrams a day. I would agree with that. So the issue here is, of course, the patient has persistent symptoms, right? Arguably class 3, and this is the kind of patient that would have been entered in the RAILS trial. Now, the issue of hydralazine isodil comes up. So in the AHEV trial, about 40% of the patients were on background spironolactone to start with. And that was a very important part of that trial design, is that patients were treated at the time recommended medical therapy. And so it was in the background of that. Also, just a couple of caveats about the hydralazine, Isodel, and NAF. Did anybody remember the dosing for that? This comes up in clinical practice all the time. What are the doses used? They were frankly based upon the old VHF data, I mean. It was actually 75 milligrams, right, of hydralazine, TID, and how much isosorbide dinitrate? 40. It's a much larger doses than I think most of us often prescribe in clinical practice. There was a formulation called Bidil. Is Bidil even available anymore still? Anybody know? Yeah, it's one of the issues in the trial was there was almost a 30 to 40% dropout rate, or not dropout rate, but there was a 30 to 40% rate of difficulties with headache and lightheadedness. And I would tell you in my clinical practice, I've seen that too. 2 weeks later, the patient's still having tremendous headaches and dizzy, and you're saying, stick with it. And it's very, very hard. And I think that has been, at least translating the AHEF trial into clinical practice, I think, been one of my personal bugaboos in trying to get that done. All right, well, we move on to the next trial. So somebody commented the headache does go away eventually. It often does, but in many of my patients, I can't, 2 weeks later, a month later, I still have headaches, and then we end up stopping it. So, but it's a good one. Yeah. Okay, what drug has no clinical effect on heart rate of the transplanted heart? Metoprolol, adenosine, terbutaline, digoxin, and thiophanate, and we're going to talk probably a little bit more about this today. Digoxin, yeah, and that's pretty straightforward. We're going to talk a little bit about this in about an hour. Digoxin works, of course, right by increasing parasympathetic influence, particularly vagal tone, and the heart's denervated. So it's really going to have no parasympathetic innervation, making it unlikely to have any benefit or effect. Remember, the heart is denervated, so a lot of its contractile and chronotropic response is related to circulating catecholamine, so beta blockers are often poorly tolerated. Adenosine typically has a accentuated effect. We often take advantage of the effects of terbutaline and theophylline after transplanted patients are bradycardic to try to get their heart rate up before we pace. All right, 22.
You were assigned a new female patient who presented to the emergency department with symptoms diagnosed as acute heart failure. Compared to your male patients with acute heart failure, this patient is more likely to be A, younger, B, to have an ejection fraction greater than 40%, C, to have an ischemic etiology, D, to have worse 30 to 60-day outcomes, E, to have fewer comorbidities than a male with the same presentation. Oh, great. Yeah, the majority of you got this right. So you're kind of driving at the presentation of someone with heart failure and a preserved ejection fraction. Some stereotypes are certainly true, tend more often to be women than men, are more likely to be older than younger, are more likely to have high blood pressure and occasionally diabetes and obesity. The outcomes with heart failure and preserved ejection fraction, it's a little bit debatable. Some outcome studies have showed that the outcomes are equivalent to heart failure and reduced ejection fractions. Others that it's slightly worse than heart failure and reduced ejection fraction. I think the current thinking, though, is that the outcomes are slightly better than with HFrEF.
You were asked to evaluate a 32-year-old woman with a history of a non-ischemic cardiomyopathy who had an axial flow LVAD implanted 12 hours prior. Since returning from the operating room, her urine output has been 10 to 15 cc's per hour. There's been minimal bleeding. The PA catheter readings show an RA of 22, a PA pressure of 40/20, a wedge of 12. The mixed venous status 45%. Current medications include milrinone, 0.375 micrograms per kilo per minute, dobutamine at 7.5 micrograms per kilo per minute, and epinephrine at 0.04 micrograms per kilo per minute. The patient's also on inhaled NO at 40 parts per million. The most likely diagnosis is thrombus obstruction in the LVAD, pericardial tamponade, right heart failure, and hypovolemic shock. Yeah, I think most people were comfortable calling this right heart failure. High filling pressures on the right side, low filling pressures on the left side. A lot of inotropes, low cardiac index is right heart failure. Reason it's not pericardial tamponade. The LV filling pressure is low, right? Hypovolemic shock, well, RA at 22 is not hypovolemia. Thrombus obstruction in the LVAD. Arguably, you'd also expect a high filling pressure on the left side, right? Go ahead.
Okay, so we're going to jump into this in about an hour, hour and a half, talking about allosensitization and cross-matching. So as a little bit of a teaser, this is question 24. A multiparous female recipient has no HLA antibody detected by flow PRA. A cross-match between recipient and potential donor is clearly positive. Additional testing reveals that recipient had an HLA-B82 antibody and that donor had HLA-B82 antigen. Which of the following is the most likely cause of negative flow PRA and positive cross-match? A, the positive cross-match is due to a non-HLA antibody. B, the positive cross-match is a laboratory error. C, the antigen was absent from the screening panel. Or D, the negative flow PRA is a laboratory error. Yeah, very good. The majority of you got this right. The antigen was absent from the screening panel. So just to walk through that, why the other answers are incorrect. The positive cross-match is due to a non-HLA antibody. Well, we know it's actually due to an HLA antibody because there's specificity for that B82 class 1 antibody. The positive cross-match is a laboratory error. Unlikely. It was a well-performed cross-match. The last answer could be correct. The negative flow PRA is a laboratory error. So that's highly unlikely, but it is possible. So when you look at these solid phase assays that are using beads, sometimes the amount of protein that sticks to the bead can fall off. The protein can fall off the bead. But because they're so supersaturated with the protein, it's unlikely that it would be a laboratory error. So the correct answer is that the antigen was absent from the screening panel. So the way the flow PRA works, you can have multi-antigen beads, which are HLA class 1 or class 2 specific, and they have multiple HLA proteins on the bead, but they may not have the one that this particular patient has. And I think the fact that it was put up as a B82, which is a pretty unusual antigen, it may not necessarily have been on that MHC class 1 bead, which used multiple antigens.
A previously athletic 38-year-old female presents with exertional dyspnea and lightheadedness. The echo shows an RV systolic pressure of 90 millimeters of mercury. Evaluation for lung disease, chronic thromboembolic pulmonary hypertension, connective tissue disease, liver disease, and HIV is negative. The cath shows a mean arterial pressure of 60. The wedge is 10. The cardiac output is 5. When given IV epoprostenol in the cath lab, her mean PA pressure decreases to 38 millimeters of mercury and her cardiac output increases. In addition to warfarin, the most appropriate initial therapy is inhaled iloprost, sildenafil, DIG, and diuretics, amlodipine, intravenous prostanoid. In addition to warfarin, the most appropriate initial therapy is amlodipine. Now, do you folks understand why people might choose that? Because of the vasoreactivity in the cath lab, right? So there are a lot of ways to assess vasoreactivity in the cath lab. Other people use nitric oxide, anything that's going to selectively lower the PVR. When you have this very dramatic response in the cath lab, the current recommendations are to use high-dose dihydropyridine. Now, the doses that you have to use are quite high. This isn't 5 or 10 milligrams of amlodipine. In some of the original nifedipine trials, patients went home on 240 milligrams of nifedipine. So the biggest problem with this approach is trying to stand up on that much amlodipine. And the number of patients that actually have this response is relatively small, and most modern cath labs estimated incidence of seeing this response is about 5%. Some people would even say less. In my own personal experience, I've had a handful of people over 20 years, but pretty uncommon. All right.
So question 26, a 79-year-old man with systolic heart failure is admitted with cardiogenic shock. He has been on medical therapy for 15 years for heart failure due to an ischemic cardiomyopathy and had a cardiac resynchronization therapy defibrillator CRT-D upgrade 3 years ago. Over the past 6 months, progressively he has been more fatigued and his medications were down titrated because of renal insufficiency and near syncope. He is admitted to the CCU where he initially responds well to dobutamine with normalization of his serum lactate and significant improvement in dyspnea. Over the next few days, each time his dobutamine is decreased, his lactate rises and he becomes more somnolent. 3 months ago, his peak VO2 was 12 milliliters per kilogram per minute on metoprolol. His echo revealed an ejection fraction at 20% with moderate functional mitral regurgitation, and he had evidence of a reduced excursion for some aortic stenosis, aortic valve area 1.1. Which of the following is the most appropriate next step in his management? A, home inotropes, B, percutaneous mitral valve repair, C, cardiac transplantation, D, percutaneous aortic valve replacement, or E, left ventricular assist device implantation. Yeah, very good. Left ventricular assist device implantation. So we can go through these. Home inotropes wouldn't necessarily be wrong if the patient wanted to select that. However, I think the fact that he'd failed multiple attempts at weaning and he'd had long-standing heart failure, it's unlikely that he's going to be able to live without some form of either mechanical circulatory support or inotropic support. Of the other options, percutaneous mitral valve repair, certainly debatable about the utility of mitral valve repair percutaneously with the use of the mitral clip. It does improve functional capacity for those individuals with severe 4+ MR. However, it has not been shown to have any life-extending benefit. Cardiac transplantation really is not an option given his age. He's 79 years old. And percutaneous AVR would not be an option because of his valve area is still reasonable at 1.1. So left ventricular assist device implantation would certainly be appropriate, having first engaged with him with a conversation. So it would be a choice between home inotropes, hospice care, or LVAD.
Does 79 bother anybody for an LVAD? Just out of curiosity. We've done it. Just in the spirit of full disclosure. Question 27. A 64-year-old woman received a HeartMate 2 continuous flow left ventricular assist device 6 months ago as a bridge to cardiac transplantation. Her postoperative course was uncomplicated. She comes to clinic and reports worsening shortness of breath and declining exercise performance over the past few weeks. She's well appearing with a Doppler systolic blood pressure of 75 and a heart rate of 68. The jugular venous pressure was 10. The lungs were clear. There are normal VAD sounds with a soft S1 and S2. The driveline appears intact without erythema or drainage. The speed was 8,600 revolutions per minute. Pulsatility index 6.8, power 3.2, and the flow is displayed as negative, negative, negative. She walked 260 meters in 6 minutes. Blood count showed normal white count, hemoglobin of 11.3, platelets of 244. She had a normal basic metabolic panel. The INR was 2.5. The LDH was 200. A chest x-ray was clear with appropriate device location. You decide to increase the pump speed to 9,000. The following week, she reports no improvement. Which of the following is the next most appropriate diagnostic step in her management? Is CTA, right heart cath, check pro-BNP, or echo. That's not supposed to be a clue. I think that was supposed to be left heart cath. Sean?
Actually, I got the question. It's supposed to be check plasma-free hemoglobin.
Oh, really?
Yeah.
Yeah, I think everybody would move with echo first here. That really is the first step, and some people would even do a ramp. The issue, of course, is what is going on in this particular patient. The LDH is not elevated. Typically, you would use twice the baseline or 2 or 3 times the baseline. Then there's no history of hemoglobinuria. It doesn't appear that the patient is in right heart failure by physical exam. And there doesn't appear to be any infection going on. So you would next do a echo to figure out what's going on. Any other questions about that? We got 1 more minute.
Got one question here.
I was just surprised from the beginning of the question stem that there wasn't something about giving fluids. Maybe I misread it. Oh, never mind. JP's pen. Sorry.
So the question was about fluids?
Sorry.
Yeah. Well, it's not unreasonable, frankly.
Just the line.
Yeah. All right. 1 more?
A 73-year-old man with systemic hypertension and coronary heart disease received a HeartMate 2 continuous flow LVAD for destination therapy. Postoperative course was uncomplicated. He was discharged home 2 weeks after device implantation. 4 weeks after discharge, he returns for routine follow-up. He is feeling well and participating in physical rehab. On physical examination, he appears well and in no distress. The Doppler opening pressure is 92 millimeters of mercury with a heart rate 92 beats per minute. The jugular venous pressure is 5 centimeters of water. The lungs are clear and there is mild lower extremity edema. Device parameters revealed: speed 9200 RPM, power 5.4 watts, pulsatility index 4.5, and flow 4.7 liters per minute. His medications include aspirin 81 milligrams, warfarin 2.5 milligrams, furosemide 20 milligrams. Laboratory studies show an INR of 2.2, sodium of 138, potassium of 4.1, and creatinine of 1.4. Which of the following changes in management are indicated now? A, start amlodipine 5 milligrams. B, increase furosemide to 40 milligrams. C, decrease pump speed to 8,800 revolutions per minute. D, start lisinopril 2.5 milligrams. Or E, no changes indicated at this time. Yeah, great. The majority of you chose to start lisinopril 2.5 milligrams. The clue here was the fact that the opening Doppler blood pressure was over 90. For the HeartMate 2, if you look at the instructions for use, I think the IFU from St. Jude Thoratec recommends keeping the blood pressure less than, the opening Doppler blood pressure less than 80. In the clinical guidelines, it's recommended to keep it less than 90. But in any event, the opening Doppler blood pressure here was higher than that. It was 92, and therefore what you want to do is you want to lower the blood pressure. These pumps are afterload sensitive, so if they're moving blood against a higher afterload, that shifts the HQ curve and it's going to drop the amount of flow. So if you want to increase the flow and facilitate unloading the patient, the appropriate thing to do is to lower the blood pressure. There may be other benefits to lowering blood pressure as well. There's some data from Washington University looking at a retrospective single center study suggesting that individuals who had high blood pressure, greater than an opening Doppler blood pressure of 90, were more likely to experience stroke further down the road, 6 months, 12 months, and 24 months down the road. And we certainly know from the Heartware experience that the recommendations are to keep the blood pressure low and the INR appropriately within the therapeutic range to prevent ischemic and hemorrhagic stroke. Now, we did throw in also amlodipine, and the question is one form of antihypertensive better than another? And I think given the fact that we are heart failure cardiologists, we tend to stick to the guideline-directed medical therapies first. So starting, if you want to choose a vasodilator, it's probably more appropriate to choose an ACE inhibitor over amlodipine.
Yeah, and the only other comment is that it's not going to be in the guidelines, but I mean, it's not going to be in the boards, but it always comes up this issue of recovery following LVAD implantation. And if you're going to try to maximize that scenario, you want to use as many neurohormonal antagonists as you can. So if you're going to use blood pressure medicine, you'd want to use something with neurohormonal antagonism. All right, so let's move on. We can come back to these questions at the end of the day if people would like as well, since there are more.